Welcome to today's webinar presentation by Dr. Osama Hamdy. My name is Michael Montalto. I am Senior Director of Medical Affairs at Metagenics. Today's presentation is part of the Take Control webinar series featuring Dr. Osama Hamdy. Dr. Hamdy will deliver 5 Take Control webinars on the role of nutrition intervention and lifestyle modification and will provide practical approaches for sustained and improved health outcomes for the diabetic patient. Dr. Hamdy earned his medical and doctoral degrees from Mansoura Faculty of Medicine in Egypt and his fellowship in endocrinology, diabetes, and metabolism from the University of Missouri and Harvard University. Dr. Hamdy is a fellow of the American College of Endocrinology and is currently the medical director of the Obesity Clinical Program at the Joslin Diabetes Center in Boston. Dr. Hamdy is also director of inpatient diabetes management at Joslin and an assistant professor of medicine at the Harvard Medical School. Dr. Hamdy was a member of the Nutrition Guidelines Committee of the American Association of Clinical Endocrinologists that developed guidelines for Americans in 2006 and chaired the task force that developed Joslin's clinical nutrition guidelines in 2011. Dr. Hamdy was a co-investigator of 2 landmark applied clinical research studies, the Diabetes Prevention Program and the Look Ahead trial, evaluating the long-term effects of lifestyle intervention combined with nutrition strategies to improve health outcomes in diabetic patients. Dr. Hamdy translated the clinical research results of these studies into a clinical practice model through the creation of Joslin's Why Wait program. Please join me in welcoming Dr. Osama Hamdy for today's Take Control webinar.
Hello. This is the 3rd webinar in our series about medical nutrition therapy for prevention and management of type 2 diabetes, pre-diabetes, and patient at high risk to develop diabetes. So let us first look to the general protein recommendation and see what we had been telling our patients for years and see if this recommendation should change in any way. Again, there is a lot of evidence, as you can see here in the brackets, which varies between expert opinion to weak scientific evidence. So let me start with the first one. Diabetes and normal renal function should eat between 15 to 20% of their total caloric intake from protein. Diabetes with early stage of chronic kidney disease should limit protein intake to 0.8 to 1 gram per kilogram per day. And then diabetes with later stage of chronic kidney disease should limit intake to around 0.8 gram per kilogram per day. And high protein diet are not recommended as method for weight loss. And the medical nutrition therapy, actually that affect the cardiovascular risk factors, may improve microvascular complications. So let me first challenge this a little bit. We have here protein recommended as percentage one time and as gram per kilogram body weight at one time. If we need to make recommendation, should we use percentage or should we use gram per kilogram of the body weight? The second point, which is very interesting, is that many of these recommendations are just expert opinion. There is no clinical evidence that had been mentioned here that actually against the use of high protein as method of weight loss or limiting protein to around 15 to 20%. So I would like to clarify these points in this webinar so we will be all in the same page. So let me first go back to that point. Should we give protein as gram per kilogram or as percentage of the total caloric intake? So if you look, for example, to the average population or average eating habits are between 1 to 1.5 gram per kilogram. So if you are consuming 2,000 calories per day, this will come to around 70 to 105 gram of protein per day, which is actually around 14 to 21%. So 15 to 20%. That's what the average people eat. But here is the problem. If you fix this percentage around 15 to 20%, and you reduce your caloric intake to 1,500 calories per day, or you reduce it to 1,200 calories per day, then because of that ratio is fixed, you're now eating less absolute amount of protein. It will be down to 52 to 79 gram per day, which actually put you now at low protein intake. So every time you cut your caloric intake down to lose weight, you are actually consuming less amount of protein. This actually put people at higher risk to lose muscle mass during weight loss. So it is not recommended that you calculate your protein as percentage. You need to calculate protein as gram per kilogram, irrespective of the caloric intake. You eat 2,000 calories, you eat 1,500 calories, you eat 1,200 calories, your amount of grams of protein should be the same to maintain your muscle mass. And then the controversy here is, should we increase protein intake up and go up to 20 to 30% or 1.5 to 2 grams per kilogram of body weight, and if this safe or not? Let us first answer, do we have to reduce protein to improve kidney function? This is a concept that had been in the mind of every single physician for years, that reduce protein to save the kidney. Interestingly, a large meta-analysis that was done in 2008 showed in type 1 and in type 2 and in a mix of type 1 and type 2 in some cohorts, the impact of low protein on the estimated glomerular filtration rate is close to zero. There is no impact. And as you can see here in this meta-analysis, the effect on glomerular filtration rate is nil by reducing protein intake. When they looked in the same meta-analysis to the impact of low protein intake on proteinuria, as you can see again, there is no impact. So reducing protein in general for people with diabetes type 1 and type 2 has no impact whatsoever on the estimated GFR or in the microalbuminuria. So that's why we are no longer recommending that much reduction in protein intake in people with chronic renal disease. So what was the benefit? What was the benefit from reducing protein? Why they had seen in the old days that reducing protein in people with end-stage renal disease actually led to reduction in blood pressure and in slowing the reduction in GFR. If you look to that slide, you will immediately notice why. This is a group in white that reduced the protein intake significantly down. And immediately you can see sodium intake went significantly down. And this is reflected in the free excretion of sodium. While people who are on low protein diet or free eating in black and gray, you don't see reduction in the salt intake or the free sodium excretion. So when they did the meta-analysis and they looked between the relationship between the improvement in blood pressure and GFR in relation to protein and salt, they found that the relationship is actually with a salt intake and not with a protein intake. And you can see the level of significance here, which means that the benefit that you get from low protein is because of the reduction in salt. Because people salt the protein, they don't salt the dessert, they salt the protein. So this just for clarification. So there isn't a renal diet. And most nephrologists now agree there is no single renal diet. And the best advice for patient with chronic kidney disease is variable according to what people prefer and what is the blood test that they have, especially regarding the bad cholesterol. What about increasing protein? If there is any data to tell us that increasing protein actually deteriorate kidney function, has any impact? In reality, there is no single evidence to show that increased protein intake in patients with normal kidney function will result in increased macroalbuminuria or decline in GFR. There is no data. There is no data to show that if you have normal kidney function and you increase protein intake, you will have any impact on macroalbuminuria or the decline in GFR. Why this notion? What this notion about protein? If you look to this study, which was done in patients with type 1 diabetes, and I mentioned this study in the previous webinar, but it is important to look at this study one more time. People are eating protein, and as you know, most animal protein has saturated fat. And if you look to the quantile of the saturated fat, and 1 is the lowest saturated fat and 5 is the highest saturated fat, and you look to the odds ratio for macroalbuminuria, every time you increase saturated fat, you see increase in the odds ratio for microalbuminuria. While if you increase the protein intake in the lower panel, and again, lowest protein intake is 1 and highest protein intake is 5, and immediately you will see that increasing protein intake actually was associated with reduction, not increase, reduction in microalbuminuria. After adjustment, it's exactly the same scenario. Increase in microalbuminuria with increasing saturated fat, and reducing microalbuminuria with increased protein intake. So you can see here in the Nurses' Health Study, which included 60,000 nurses, what is the impact of protein intake over 11 years on people with normal kidney function and people with mild renal insufficiency. And you will find that the reduction in the glomerular filtration rate is nearly nothing in people with normal kidney function, and it is slightly up in people with mild renal insufficiency. But mind that this reduction in the GFR over 11 years, which is very slightly higher than what you will see in people on the actual average protein intake. But the conclusion of the study is that high protein intake was not associated with renal function decline in women with normal kidney function. So again, I'm repeating this point that increasing protein in people with normal kidney function has no impact on the decline of GFR or increase in microalbuminuria. In the same study, when they looked to women who are eating more protein, and here is a quantile of protein intake, 5 is the highest protein intake, and when they look to the risk for ischemic heart disease, actually the risk is lower by around 25%. So people who are eating more protein has lower risk for ischemic heart disease. What is the origin then of this recommendation that protein should be lower to around 15 to 20%? Actually, most of this data came from one study that was done in Europe. It's called EURODIBIDOM, IDDM. It was done among patients with type 1 diabetes. The study was done in 30 centers, 16 European countries. But it is a cross-sectional study. It is not a prospective study. So it is not that you are giving them higher protein and you look to the albumin excretion rate. This is a cross-sectional. So you are looking for people who are eating higher protein or lower protein and see what is the albumin excretion rate. Those study came with a conclusion that protein intake less than 20% will end up with albumin excretion rate less than 20 milligram per minute. But protein intake more than 20% will end up with albumin excretion rate more than 20 milligram per minute. And then the study came with a conclusion that it is recommended for people with diabetes not to increase protein intake more than 20%. But let me go back and read this study, because it's very important sometimes when we see a conclusion on the results of one study that had been quoted several times, you go back and read that study and see if that study is telling us the same message that is shown in the conclusion. So let me look first to the left panel. And if you look to the upper histogram, you will see increase in the albumin excretion rate in that line with the increase in the protein intake. So people who are taking more than 24% of their caloric intake as protein has the highest albumin excretion rate. But if you look down to the middle panel, you will see that if you separate those people into people with diabetes who are well controlled and people with diabetes who are not controlled, you will see there is no impact of higher protein intake on the albumin excretion rate in those people with diabetes and controlled diabetes. While in people without good diabetes control, you will see increase in albumin excretion rate. In the lower one, if you look to the blood pressure, again, if you look to the normotensive patients, the increase in protein intake has no impact on the albumin excretion rate. And the increase in blood pressure, people with hypertension, they have increase in the albumin excretion rate. Although you see the line is like zigzag line, it is not like straight line. But what is interesting, if you look to the right-hand side, and here is now you combine the diabetes control and blood pressure, and you look to higher protein and lower protein. So what's very interesting, if you look to normotensive patients, whether they have controlled the diabetes or uncontrolled diabetes, actually there is no difference in the albumin excretion rate between high protein or low protein. Where you will see that difference? You will see that difference in people with hypertension, especially if their diabetes is not controlled. So in reality, this study is telling us that the problem with microalbuminuria is related to the blood pressure. It is not the protein. It is not the protein intake. It is the blood pressure. If you control the blood pressure, you will definitely reduce the microalbuminuria and the albumin excretion rate. What is interesting, if you look in the text of the study itself, you will see very interesting comment. So in this study, we observed that albumin excretion rate was associated with the presence of hypertension or higher A1C, but there is weaker relationship with dietary protein intake. The same study that is limiting protein is saying here there is weaker relationship with protein intake, and the most of the relationship is with high blood pressure. Also in another text, they say that the relationship is not with vegetable protein, and it is not if the protein is calculated as gram per kilogram of the body weight. So that's why this study shouldn't come with that conclusion. The right conclusion for this study, which is again cross-sectional study, is that hypertension is related to the increase in albumin excretion rate, especially in people with uncontrolled diabetes, and there is weaker relation with protein. So what about protein? Let us think a little bit about protein and what is the impact of protein on blood glucose, on body weight, and in many other parameters like lipid profile. First, let us evaluate the impact of protein intake on blood glucose level. As you know, protein is amino acids. And if you take any amino acid, the fate of this amino acid is ammonia group that combine with carbon dioxide and produce urea. And then the carbon group, which is actually became as glucose. So in reality, every time you eat protein, you end up with glucose in your circulation. Way back in 1915, they understood that if you eat 6.25 grams of protein, this will give you 3.5 grams of glucose, which means that if you eat 100 grams of protein, it will give you 56 grams of glucose. So it's very interesting. What if we give people 100 grams of protein or 56 grams of glucose and see what is the impact on the blood glucose level? This experiment was done in 1924, way long. That's why those people during this time may know more about medical nutrition therapy than what we know right now. What they found is that if you give 50 grams of protein or equivalent 25 grams of glucose, and you look to the blood glucose level at fasting and 5 hours later, you will not see any increase in blood glucose level with the protein. But if you give the equivalent amount of glucose as glucose, you will see increase in the blood glucose level. So when they repeated this study in healthy population and people with type 2 diabetes, and they give them 1.3 pounds of beef, which if you give them, it will give you 68 grams of glucose. So they give the beef at one time and they give the glucose, equivalent amount of glucose at one time. And they looked at the blood glucose level over 8 hours. And what they found was also the same observation. You give protein, there is no increase in blood glucose level for 8 hours. And you give equivalent amount of glucose and the blood glucose goes up. The same, you see it in people with diabetes. But when insulin was discovered, insulin assay was discovered, they start to look to what is the impact that you will see if you give protein to healthy population or people with diabetes. If you give it to healthy population, you will not see any increase in the blood glucose level. This is the left panel in blue. Healthy population, you give them protein, there is no increase in the blood glucose level for 5 hours. But if you give it to people with diabetes, it's very interesting. Beyond the 2 hours, the blood glucose goes down, not up, goes down. So why down? When they measure the insulin level, they found that in healthy population, insulin level goes up in response to protein, but it goes significantly up in response to protein in people with type 2 diabetes, which means that people with diabetes in general, they may not respond to the glucose stimulus as much as they are responding to protein stimuli. We know now that many of the amino acids stimulate the beta cell to secrete insulin in good amount. So this is interesting. But what is interesting is if you add protein on the top of carbohydrates. So Mary Gannon and Frank Notel did a very interesting study, and they gave people 50 grams of glucose. And then they started to add protein. Now, if you add protein, you are giving people more calories, but also you are giving them more glucose. So you always expect that the blood glucose will go up. But interestingly, they found that every time you add protein to the carbohydrates, actually blood glucose goes down. And based on what type of protein that you are using, you see reduction in the blood glucose level, which means that it is not all about calories. It is not all about carbohydrates. It's about protein as well. And adding protein will reduce the blood glucose level because, again, this was clear in the previous slide. There is more stimulation of the insulin secretion by protein. Interestingly, in the study that was done to compare giving 15% protein in low-calorie diet in comparison to 30% protein in low-calorie diet, A1C went down by around 0.8% just in 5 weeks. I just remind you that if you give pioglitazone or metformin and you measure the A1C in not in 5 weeks, in 12 weeks, you will see a reduction of around 0.7 to 1.4. 5 weeks and A1C is down by 0.8 just by increasing protein intake is very impressive. It is very clear for us that increasing protein intake has actually more impact on the blood glucose level and reduce the blood glucose level, and they don't increase the postprandial blood glucose level or even lower the postprandial blood glucose level. So what is the impact of high protein on body weight and fat mass? Before we go into the effect of high protein on body weight and fat mass, I would like to remind you that people without diabetes, as they get older, they lose around 300 grams of their muscle mass per year. People with diabetes lose more muscle mass per year. People with undiagnosed diabetes or uncontrolled diabetes lose approximately around 1 pound of the muscle mass per year. So as we get older, we lose muscle mass. So if someone has diabetes for 20 years, that person already lost around 20 pounds of the muscle mass. This is what's called the sarcopenic obesity. That's why in weight management, you are not only giving protein, but you also need to increase the amount of strength exercise to keep the muscle mass up during that weight loss. So let us go back to the study that I mentioned in the previous webinar. Here is 3 categories of population randomized. They cut for all of them the caloric intake to the same extent. But one group, they kept their carbohydrate percentage high, around 49%. So here in orange. And then the second group, they give them higher fat. So 57% of their caloric intake is from fat. And then the third group in blue, they give them higher protein intake. So 35% of their caloric intake per day is from protein. People usually say calories are calories. They expect that it is exactly the same weight loss. The 3 groups, higher carbohydrate or higher fat or higher protein, cut the caloric intake by 500 calories. They should lose the same. But in reality, the study showed that actually only those people on high protein or high fat lost weight. So the group who was on high carbohydrates actually didn't lose as much as people who are on high protein and high carbohydrates, even with a reduction in caloric intake to the same level. So which one to choose, high protein or high fat? You know, the differentiating point is what is the impact on LDL? Because every time you eat high fat, you eat more saturated fat, more trans fat. And actually, they found that 25% of those people on high fat has increase in their LDL more than 10%. You see also increase in carbohydrates, but nearly only 3% increase in LDL in the high protein group, which means that high protein as a method of weight loss is actually accepted and beneficial. So in another study, here is again the increased protein from 15 to 30%, and they reduced the carbohydrates from 55 down to 40%. And this was constant amount of fat. The fat is still 30%. What they had seen here, again, on higher protein, there is more weight loss than in lower protein. Both of them reduced the insulin. Both of them reduced the CRP and markers of endothelial function. And both of them increased HDL. But the fat reduction had been higher in the group that has higher protein. So there is more fat reduction in the group. And again, if you look to the impact of this diet in another study on bad cholesterol, LDL, the group who ate higher protein and low carbohydrates have more reduction in the LDL cholesterol in comparison to those who reduced the protein, but still on higher carbohydrates. Again, if you look to the ratio down, you will see the protein went up from 16% to 28%, and the carbohydrates went from 55 to 42%. So it looks like this national experiment, which I explained in the last webinar, when you recommend going up on the carbohydrates, was a big mistake. But if you need to correct that mistake, the 10% that you cut from fat, add it to protein. You need to have more protein. And as I mentioned, this has no impact in people with normal kidney function on GFR or in macroalbuminuria. Actually, people lose more weight, and there is even reduction in microalbuminuria in this population on higher protein intake. What about fat mass? And especially fat mass in women. Again, if you give low protein, which is in orange, you will not see impact on fat mass in women, but you will see significant reduction in the fat mass in women when you give them higher protein intake. So this, again, another advantage. So there's not only weight loss, not only reduction in the LDL, but also reduction in the fat mass. And again, back to that study, which showed that there is a reduction in the glucose area under the curve. In that study, the fat intake was 30%, the protein intake was 30%, and the carbohydrates was 40%. And this is in comparison to the higher carbohydrates of 55 and the low protein 15. So what you did here is you increase the protein to 30% and reduce the carbohydrate to around 40%. And what you see, again, 40% reduction in the glucose area under the curve. And this was translated into reduction in A1C by 0.8%. And you see also reduction in triglycerides. In that study, one good observation is that is not only the glucose area under the curve is down to 62% of its original value, and then you see on the right-hand side, which is also important, the insulin secretion. Insulin secretion went up by 18% when you increase protein from 15% to 30%. So again, this is definitely in response to the amino acids and protein that stimulate the beta cell. Again, back to maintenance of weight loss. So those people who lost initially 8% of their body weight, and then they look to those people and focus on the right panel, combination between protein and low glycemic index in relation to the maintenance of weight loss. Actually, the group that maintained the weight loss for longer duration is only the group that ate high protein and low glycemic index carbohydrates, which again is telling us that this combination of high protein, low carbohydrate, especially low glycemic index carbohydrates, you will see maintenance of weight loss. If you have high protein but high glycemic index, you can see still weight regain. So this is advice that we can give to our patients if they would like to maintain weight loss for longer duration. Eat more protein and less carbohydrates, especially lower glycemic index carbohydrates. So what is the take-home message from this presentation? The first is that we should calculate protein as gram per kilogram, not as percentage. Because every time you calculate it as percentage, if you cut the caloric intake down to lose weight, you are actually reducing the amount of the absolute protein. And this is extremely dangerous. You lose muscle mass. You put yourself at risk for protein malnutrition. Especially if you are not doing any exercise, you lose significant amount of the muscle mass. If you lose the muscle mass, unfortunately, you will not get that muscle mass back in an easy way. The second take-home message is that reduction of protein intake actually doesn't have any impact on microalbuminuria or on the rate of decline in the GFR in people with end-stage renal disease. So we need to stop that practice because clinical trials showed that you can only postpone dialysis by like 6 months. But when people go on dialysis, they have protein malnutrition, they have microalbuminuria, they have edema, and the mortality is significantly high when you reduce protein intake. I see most nephrologists are departed from this. The MEDRD study didn't show any benefit from cutting the protein down. On the other side, increased protein intake, as we had seen, improved blood glucose, reduce the area under the curve by 20%, increase insulin secretion because many amino acids stimulate insulin secretion, reduce A1C, and you had seen in one study it reduced A1C by 0.8%. If you combine it with low glycemic index, you can even reduce the A1C by, as I mentioned in the first webinar, by around 0.4%. So you have like 1.2% reduction just by increasing protein and lower glycemic index. This is better than many diabetes medication. But that combination of higher protein and low glycemic index helped people to maintain weight loss for longer duration. So increased protein intake enhances weight reduction. We had seen this in several trials, reduce fat mass, especially in women, and maintaining the weight loss, as I mentioned before, if they are combined with low glycemic index carbohydrates. So we need to clear that myth. These are the facts now. And I think if we need to make solid recommendation for our patients, we need to ask them to reduce carbohydrates down, especially reducing the glycemic index, increase protein intake and calculate it as gram per kilogram, 1 to 1.5 gram per kilogram, irrespective of the caloric intake, do strength exercise to maintain the muscle mass, reduce the glycemic index in combination of the high protein to maintain the weight loss for longer duration. So what we are expecting in the coming webinar. The coming webinar, I will put all the medical nutrition therapy all together. And then we will discuss some of the optimal nutrition strategy for weight reduction and for prevention and control of diabetes. We'll show you one of the data that we had published in Lancet recently about the nutrition strategy for management of diabetes and for prevention of diabetes. And we will ask, can we prevent diabetes through lifestyle intervention? What is the data that we have? How we can do it in clinical practice? What specific food is associated with reduced diabetes risk? Do we know that blueberry, for example, or decaffeinated coffee can have impact on diabetes risk? We'll answer this in the coming webinar. And then what is the best dietary pattern? We hear about Mediterranean diet, DASH diet, vegetarian diets. We need to see what is their impact on prevention of diabetes. It's very interesting. A lot of people would like to start their day with coffee, and some of them end their day with decaffeinated coffee. What is the impact on diabetes risk? And finally, we will discuss, do the current recommendation for medical nutrition therapy reflect the recent clinical evidence from meta-analysis, observational trials, and randomized clinical trials or not? And why we need to fill some of the gaps in knowledge that we have and how we can come with a stronger recommendation. I think medical nutrition therapy can be very effective in managing diabetes, in prevention of diabetes, and in controlling obesity, and lead people to have a very good, healthy life with very good quality. Thank you very much.